Hi Ninja Nerds, in this video we're going to talk about abdominal aortic aneurysms. If you like this video, please give it a thumbs up and let's get started. Abdominal aortic aneurysm, also referred to as AAA, is this medical term that we're going to be talking about today that is so long, so let's break down the word and really understand what we're talking about. The first thing is the abdominal. We're going to be talking about the abdominal aorta, which is the aorta that is below the diaphragm in our abdominal cavity. And remember that the aorta is the largest vessel from our heart that supplies blood to the rest of our body. And then the word aneurysm. What does the word aneurysm mean? Aneurysm is defined as this widening or this weakening of the aorta that causes this bulge or this outpouching. It also can be given as the word dilation. All right, so it's a dilation or weakening of the aorta, right? What does that mean? What does the word dilate mean? So another word that I like to use is the word ballooning. So we're looking at the aorta here. You can see the red and then you can see the darker red. The bright red is our normal size and diameter of our aorta, but as it gets to this portion here, the aneurysm is a dilation or a ballooning out, this widening here. So you want to look at that. So with that widening, it's really important to just take note of what else is around that area, what else is surrounding this aneurysm. We have things like the inferior vena cava, which is right here. And then we have our kidneys, especially if this aorta this aneurysm were to get so big, it could actually press up onto our renal vessels here. So just keep that in mind as we talk about things later in the video that refer to our kidney. All right, so we talked about where the abdominal aortic aneurysm is, or the AAA is, but let's talk about why this is occurring. What are some risk factors that could be causing this to occur? The first thing we're going to talk about is right here, this buildup of plaque, which is fats and cholesterol. What do we call that? That's our atherosclerosis, right? So that's what we define as this buildup of plaque and this narrowing, this hardening. What this does is this takes our nice elastic vessels that can stretch and move with our blood flow and our blood pressure, and it makes them hard and makes them rigid. So then what happens when we have that hard and that elasticity taken away, they become narrow and they become harder to push blood through. They can increase our blood pressure because of this buildup, with this narrowing, and that creates a pressure somewhere else that can occur, this aneurysm, right? This backlog of pressure that's going to cause this ballooning. So we have atherosclerosis. What else besides this plaque buildup that's causing this issue that's building up in our blood pressure and then possibly causing more strain on our walls? We have smoking, right? What's this right here? Smoking is another risk factor. And smoking isn't particularly important because we can modify it and just stop smoking, which hopefully then can take away our atherosclerosis. But smoking can also cause hypertension or an increase in blood pressure. That'll also cause some issues for us. So because of the smoking and the atherosclerosis and the high blood pressure, we're causing the strain on the vessels. What are other risk factors that can also attribute to these? One of those can be obesity, our age, and being male. So these risk factors are defined as our risk factors that can increase the chance of having a AAA, particularly smoking, atherosclerosis, and uncontrolled hypertension. Because of that, we want to be talking to our patients and we want to maybe modify these causes, modify these risk factors. Okay, one of the other ones that we can modify as well is obesity, but we can't really modify that we were born male, and we can't modify how old we are. So let's talk about that. What's the first thing that we can do is we can stop smoking, right? If we stop smoking, we can hopefully decrease our blood pressure, we can decrease our risk of atherosclerosis. But if we can't, what are some other things that we can possibly do? Two things that we can do is pharmacological or losing weight management. And these are two things that we can do. What are they? We can do that with our hypertension, and we can do that with our lipid disorders, right? Which can also be attributed from our atherosclerosis, our high blood pressure, and our smoking. So let's keep that in mind. So we have our patient, we tell them, you have these risk factors. They could be leading up to a AAA. You want to modify them. They don't modify them. And we find somebody who has a AAA. So we're going to talk about the signs and symptoms of AAA. This is interesting because typically people that have a AAA have no idea that they actually have one. They're usually found coincidentally when they're doing some other testing, or they're just looking for them. They don't really have any signs or symptoms, but they're just looking for them. So one of the biggest things is that people that have AAAs are asymptomatic. They don't have really any symptoms. We just found it because they came in maybe for some other routine ultrasound because they're over a certain age, because they are a smoker, because they do have blood pressure issues. We want to make sure that they don't have a AAA. Or we find it coincidentally because maybe they're coming in for some type of ultrasound or CAT scan of the abdomen, and we found it. But one of the biggest signs of a AAA, if they do maybe have it or having some complications with it, are back pain or abdominal pain. Okay. And we know as nurses that if a patient comes in and they're having some type of abdominal pain, we're going to be doing our look, listen, and feel. We're going to be assessing that abdominal cavity. We're going to be looking at our patient and checking them out. So when we look, listen, and feel, the first thing we're going to be doing is looking, right? We're going to ask them, lift their shirt up, or can you pull your gown up, please, so I can take a look at your abdomen. And we're going to be looking at color. We're going to be looking at size or shape. And we're going to be looking to see if anything is pulsating. Okay. Right. You're going to know other things like scars, any type of markings on the skin, things like that. Once we look, if we do see something pulsating, we're not going to feel, okay? But if we don't see anything that is of the pulsating out of the abdomen, we don't see anything that looks like it's leaking or anything like that, an open incision, we can then go on to listen. So with the listening portion of our assessment, we want to make sure that we are asking the patient where their pain is, particular note to where that pain is, because typically when a patient has an aneurysm, you may hear the sound a little bit to the left of the patient's aorta. So we're going to listen. And what are we going to listen? We're going to listen and we may hear a bruit. What is that? What is a bruit? A bruit is this turbulent flow, right? We have this blood that's getting pumped out of the heart. It's coming down the aorta. And when it comes through, it kind of gets turned through this before it gets pumped out. And that turbulent flow creates that bruit sound. When we listen to, we also want to make sure that we're listening in the 4 quadrants. Remember, it's 1, 2, 3, 4. Okay, because we're listening in the path of our colon to make sure that we're finding any blockages or anything like that. So our patient, we're looking at the color and size. We're looking to hear a bruit. And the last thing would be to feel. That's where you're just going to palpate. Okay, and palpate all the areas, making sure there's nowhere else in particular there's pain. But we call our doc and we say, hey doc, patient in room, blah, blah, blah. I heard a bruit over their abdomen. They're complaining of pain. This is their assessment. These are their vital signs. I think they may have a AAA. They're going to get their ultrasound, they're going to get their CAT scan, and hopefully diagnose them with a AAA before we have any other issues like a rupture. But there always is that chance that this aorta can build up, or aneurysm can build up so much pressure that it bursts open. And we're going to talk about that, about what we should do when we have a rupture. Now we're going to talk about the signs and symptoms of a rupture. So this is something we don't want to happen. However, some patients know they have a AAA and they're able to live with that. They say, okay, when that happens, that happens. But some people don't know that they have a AAA, and it does happen to rupture. So what are some signs and symptoms? What are things that we're going to be looking for? The biggest thing is usually the patient explains their symptom as a tearing or a ripping feeling. And because we're talking about a AAA, which is in the abdomen, that's where their pain is typically going to be. So they have this tearing, this ripping pain that they felt in their abdomen. And when it ruptures, we have to remember that we're talking about the aorta, right? The heart is pumping out this blood, it's pumping it out fast, it's coming out fast. So we're going to be looking for signs and symptoms and moving really quickly of hypovolemic shock. So this patient's probably dissecting or they're hemorrhaging out, and we're going to be looking for those signs of hypovolemic shock. So what are those? What are some things? So there's going to be an increase in the heart rate due to a decrease in the blood pressure, right? They're going to be hypotensive. They're going to be tachycardic. What else is going on? There may be a change in the mental status. What else? The pulses obviously are going to be going down. And the last symptom here would be diaphoresis, or that sweating. So what we're looking for are these signs and symptoms, right, of hypovolemic. Hypovolemic shock, right? Because this is going to happen really quickly. It's going to rupture, patient's going to hemorrhage, they're going to dissect, and hopefully we can get to them in time. But this is one of the things with AAAs that they can dissect and they can hemorrhage very quickly. But hopefully we have diagnosed our patient with a AAA, they know they have a AAA, and we're going to be able to get them into surgery, get a stent placed, and hopefully never experience a rupture. So we're going to talk about surgery here. What are the three different criteria that a patient has to meet in order for them to get surgery? The one is a aneurysm that's greater than 5.5 centimeters, one that maybe is rapidly growing. So they had a CAT scan 3 months ago and there wasn't any type of bulge, and now they have a pretty significant bulge or an aneurysm that we want to maybe get surgery. And the last would be what? We have something that's really big, one that's rapidly growing, or symptomatic. Symptomatic. There we go. All right. So symptomatic, rapidly growing, or greater than 5.5 centimeters. So this patient meets criteria, so we're going to be able to get them into surgery. So what are we going to be doing? For pre-surgery, which is very important because if we have good pre-surgery prep, then our post is going to be a lot better. The first thing is going to be an X. We want to make sure we're marking our pulses. Okay. This is a really big important one. The NCLEX likes to ask about this, marking our pulses with an X, and particularly the posterior tibialis or the dorsal pedis. The reason we're doing this is not only because now you can find it and it's a lot easier. It's for consistency and to be congruent through all of our care. So if I have this patient for 12 hours, I've been checking their pulses on the X's, I've been marking them into my charting and documenting them, and then the next nurse comes in, or the doctor or whoever did the surgery is coming in, they're checking at the same spot. So we're all consistent with where our pulses are being checked, because with a patient that's recovering from surgery, especially AAA surgery with the stent placement, we're going to be looking for their distal pulses, or the pulses below that site. And one of those is basically the posterior tibialis or the dorsal pedis. What's another thing for surgery? Big NCLEX question, they like to ask it anywhere and everywhere on any surgery patient, is was there consent signed? So make sure we have consent. And then we're just going to make sure we have baseline data. We're going to be assessing our patient all over, but one of the biggest ones is any type of change in mental status. So we're going to be checking our neuro, and then we're also going to be checking our renal, right? Why are we checking mental status? We're checking mental and neuro because if a patient is losing blood, one of those things that can occur really quickly is a change in mental status. We're also going to be checking their renal. Why their renal? If there's any issues with volume or volemic, right, shock, so we're looking for hypovolemic, it's going to show up in their renal, their output, right? So we're looking at their urine output, and what should their urine output be? What is the number that we're always looking for an adult? 30 milliliters per hour. Okay. So pulses, consent, neuro and renal status, and then the last thing, if you have time, so hopefully you can teach them about their breathing exercises. So a patient that is going to be having any type of surgery typically is going to need to learn some breathing exercises. We have an incentive spirometer here, and we also can teach them deep breathing exercises. Important because once they have surgery, they might be on a little bit of pain medication, they might be a little bit altered just from having anesthesia, and patients with abdominal aortic aneurysm repair, they sometimes have a long incision straight down the abdomen here. With that, when you have breathing issues, they're not going to want to take a deep breath in, so we want to maybe help them with teaching of the incentive spirometer, teaching them those coughing exercises, and how they're going to then splint, which we're going to talk about in a second. So moving on to post, our patient went, we had a AAA repair, they have a stent in there, and now we're going to be looking at what are signs and symptoms or how we're going to care for them afterwards. So we're going to be looking for two things. We're going to be looking for signs of occlusion, or a sign of leakage. Right? And what does the word occlusion mean? A block. So we're looking for if there's any type of block or buildup somewhere in one of these openings, or anything from the incision, okay? And we're also going to be looking for any type of leakage, something coming out around the stent, okay? So what are some signs of occlusion? What are some signs of leakage? We're going to be looking for any changes in blood pressure. We're going to be looking for any changes in pulses. We're We're going to be looking for changes in mental status, in our output. What else? What are we looking for? Why are we teaching the patient, let's look for leakage, let's look for blockage? We're basically trying to make sure that they aren't going to go into what type of shock? Hypovolemic. And remember, especially with leakage, this is the biggest thing, and this is the one that the NCLEX likes to hit on. If there's leakage, right, here's our patient, all of a sudden there's leakage around this site here, or leakage around this site here. What is this area right here? This is our groin, or our perineum, right? So this is where we're going to be looking for our patient. If there is leakage, we're going to be looking for bruising, the groin, the penis, the perineum, the scrotum. If it's a female, labia, we're going to be looking in this area because that's where that leakage is going to occur. And because of the leakage, remember, then we're going to have a change in pulses, we're going to have a change in blood pressure, we're going to have a change in our output because we're not perfusing the way we should, okay? So we're going to be looking and keeping signs of hypovolemic shock. Because we're nurses, we're smart, we're ninja nerd nurses, we're trying to stay ahead of the game here. What are some of the things that we're going to do in order to monitor our patient to make sure that they aren't having any signs of leakage or occlusion? All right, what are we looking at? We're going to be looking at a CBC. We're going to monitor their blood. We're going to monitor their hematocrit and their hemoglobin, right? Keep an eye on that. We're going to monitor their output. We're going to make sure that their blood pressure is good. We're going to make sure that they're splinting when they cough or taking their deep breathing exercises. And usually they give a little bear or a pillow, really cute. And the last is at the head of the bed is going to be lower or at least 45 degrees because we don't want to be pinching off or occluding this new stent that now has been placed in our aneurysm. So because of this, we want to make sure our patient, they've been in the hospital maybe 2 days now and they're going to be going home. This is fantastic news for us. We want to make sure that we're educating them. And when we educate our patient, we're educating them on everything that we were also looking for. And we're also going to educate them on what they can and can't do when they are at home. So the biggest thing is first is lifting. So remember, they don't want to be lifting anything greater than 15 pounds for at least 6 to 12 weeks because they could be building up pressure, causing a rupture, causing any type of leakage around that opening, whether it's the one on the outside of their body or the one on the inside where they put the stent in. We also want to make sure that they consult their doctor for driving, so no driving until they are seen by their healthcare provider. We want to teach them about blood pressure. They got to be monitoring their blood pressure. If they're on blood pressure medication, we want to teach them about blood pressure management and medication. So getting up slowly when you're changing positions, making sure we're taking our blood pressure in the morning before we do anything else. Okay? What else about education for a patient going home? We don't want them lifting, we don't want them driving, they're going to be taking blood pressure medication. What are the big things we want to be telling them to look for? Remember, it's going to be that bruising, right? We're going to be making sure there's no bruising or ecchymosis in our area. There's going to be any changes in mental status, changes in pulses. Now for patients, they're probably not going to be checking their pulses, but what are things that you can tell them to do that would make their pulses or indicate to them that their pulses change? What's the thing that we can also do instead of checking pulses? Cap refill, okay? So we're going to teach them about cap refill. And what's something that's even easier, right? Cap refill is when we blanch and we go from a white back to a red. What's another thing, an even easier thing? They don't even got to squeeze their toes. They just got to look down their feet and see what? A discoloration, right? Something that's changing color. If there's any type of, your toes are starting to turn blue, man, your feet are turning blue, call your doctor. And the last thing we're going to be telling them is what? They want to make sure everything, they're bruising the area, they're changing their mental status, their pulses, they're checking their blood pressure, and what's the last thing? They're going to be doing all this if their urine output is going to be decreasing. So they have a decrease in their output. That can also be a sign they aren't perfusing and they need to call their doctor or they need to call 911 and get in for an emergency. One other thing before we go is their output, their bruising, right? We have all this signs of leakage, the sign of occlusion. The last thing would be any type of change in our abdominal cavity, or any type of bloating, right? Any type of pressure that's going out, any type of expansion or distension in the abdomen. We want to make sure they are aware of that because that could mean that there's something else going on with the stent or with the aneurysm, and you want to make sure you get checked, get a CAT scan, make sure everything looks good. All right, Ninja Nerds, in this video we talked about abdominal aortic aneurysms. I hope it made sense, and as always, until next time.